Clinical case presentation, Facioscapulohumeral muscular dystrophy, FSHD. Chief complaints. A 19-year-old gentleman presented to the neuromuscular clinic with complaints of progressive difficulty in raising both arms above the head for the past 6 years, weakness of facial muscles for 5 years, and difficulty in walking with frequent tripping for the past 2 years. History of present illness. The patient was apparently well until the age of 13 years when he first noticed difficulty while participating in sports at school. He found it increasingly difficult to throw a ball overhead and had trouble lifting objects onto shelves. Over the next 2 years, he developed prominence of both shoulder blades, which became more noticeable while pushing against a wall or attempting to elevate his arms. Around the age of 14 years, family members observed that he was unable to whistle properly and had difficulty blowing balloons. He also had difficulty drinking through a straw. His smile gradually became flattened and less expressive. Parents noted that he often slept with his eyes partially open, exposing part of the sclera during sleep. The weakness progressed slowly and asymmetrically, with the right shoulder being more severely affected than the left. He denied sensory symptoms, muscle cramps, fasciculations, or episodes suggestive of myotonia. At the age of 17 years, he began experiencing frequent tripping while walking on uneven surfaces. He found it difficult to walk on his heels and occasionally noticed his foot slapping the ground while walking, suggestive of foot drop. Despite these symptoms, he remained ambulant without support. There was no history of dysphagia, nasal regurgitation, diplopia, ptosis, respiratory distress, palpitations, syncope, or exercise-induced myalgia. There was no history suggestive of cardiomyopathy. Family history. On detailed inquiry, the patient's father had mild weakness of facial muscles and prominent scapular winging since early adulthood, but had remained functionally independent. A paternal aunt was also reported to have difficulty raising her arms overhead. The pedigree was suggestive of an autosomal dominant inheritance pattern spanning 3 generations. General physical examination. The patient was thinly built with preserved cognition. Vital signs were stable. Facial inspection revealed a flattened transverse smile with poor elevation of the corners of the mouth. He was unable to whistle effectively and demonstrated marked weakness while attempting to puff out his cheeks. There was mild leg ophthalmos with incomplete eye closure. No ptosis or ophthalmoplegia was present. Neurological examination. Cranial nerves. There was bilateral facial weakness predominantly involving the lower face. The patient exhibited a characteristic bouche de papier appearance with pouting of the lips. Orbicularis oculi weakness was evident with incomplete, forceful eye closure. Extraocular movements were full and there was no ptosis. Bulbar functions were normal. Motor system examination revealed striking asymmetry of muscle involvement. Marked wasting was present around the shoulder girdle, particularly involving the parascapular muscles. Bilateral scapular winging was evident, more pronounced on the right side. The scapulae protruded prominently during forward flexion of the arms. The clavicles appeared downward sloping, and the axillary folds were horizontal due to pectoral muscle wasting. Interestingly, the deltoid muscles were relatively preserved despite severe weakness of surrounding shoulder girdle muscles. Upper limb power assessment demonstrated shoulder abduction, 3/5 right, 4/5 left. Elbow flexion, 4/5 bilaterally. Elbow extension, 4/5 bilaterally. Wrist extension, 4/5 bilaterally. Wrist flexion, 5/5 bilaterally. The discrepancy between relatively preserved wrist flexion and weaker wrist extension was notable. The upper arms appeared disproportionately bulky compared with the forearms, producing the characteristic Popeye arm appearance. Examination of the trunk revealed weakness of abdominal muscles with a protuberant abdomen and exaggerated lumbar lordosis. When asked to lift his head while lying supine, the umbilicus moved upward, demonstrating a positive beaver sign indicating preferential weakness of lower abdominal muscles. Lower limb examination showed mild weakness of ankle dorsiflexors, 4 or 5, and hip flexors, 4/5. Ankle plantar flexion remained preserved. No contractures were noted. Reflexes. Deep tendon reflexes were preserved in the upper limbs and mildly reduced at the ankles. Plantar responses were flexor bilaterally. Sensory examination. Sensory examination was entirely normal. Gait examination. The patient walked with mild bilateral foot drop, more prominent on the right side. Heel walking was impaired. There was compensatory lumbar lordosis during ambulation. Clinical localization. The pattern of weakness localized to a primary muscle disorder, myopathy, involving predominantly the facial, scapular, humeral, abdominal, and distal lower limb muscles. Differential diagnoses: 1. Facioscapulohumeral muscular dystrophy, most likely. 2. Limb girdle muscular dystrophy with scapular involvement. 3. Scapuloperoneal muscular dystrophy. 4. Emery-Dreifuss muscular dystrophy. 5. Chronic inflammatory myopathy. Investigations. Serum creatine kinase was mildly elevated at 850 IU per liter, normal 200 IU per liter. Nerve conduction studies were normal. Needle electromyography demonstrated small amplitude, short duration, polyphasic motor unit potentials with early recruitment, consistent with a myopathic process. Genetic testing demonstrated contraction of the D4Z4 repeat array on chromosome 4q35 to 3 repeats in association with a permissive 4qa allele, confirming FSHD type 1. Pulmonary function testing showed normal forced vital capacity. Audiological assessment was normal. Fundus examination did not reveal evidence of retinal vascular abnormalities. Final diagnosis: facioscapulohumeral muscular dystrophy type 1, FSHD1, with classical facioscapulohumeral phenotype and autosomal dominant inheritance. Discussion points. During grand rounds, this patient illustrates the classical phenotype of FSHD characterized by early facial weakness, asymmetric scapular and humeral muscle involvement, prominent scapular winging, relative preservation of the deltoid muscle, Popeye arm appearance. Positive beaver sign. Early ankle dorsiflexor weakness producing foot drop, absence of ptosis, ophthalmoplegia, significant bulbar involvement, cardiomyopathy, and contractures. The asymmetrical distribution of weakness and preservation of the deltoid are particularly helpful bedside clues pointing toward FSHD. The diagnosis was confirmed genetically by demonstrating D4 repeat contraction on chromosome 4q35.